Okay, well, welcome everybody. Welcome to Oh My Aching Body. This program is brought to you by Northern Westchester Hospital's Orthopedic and Spine Institute and Center for Healthy Living. I'm your host and moderator today. My name is Amy Rosenfeld, and I am the program coordinator for the Center for Healthy Living. With us tonight, we have 4 Northern Westchester Hospital orthopedic surgeons, Dr. Victor Cabe from Somers Orthopedics and Sport Medicine Group, Dr. Evan Karras from Caremount Medical, Dr. Joel Buckhalter from Somers Orthopedics and Sport Medicine Group, and Dr. Evan Hawkins from Caremount Medical. Welcome, everybody. Thank you for joining us tonight and for giving us your time and expertise. Tonight, our surgeons at Northern Westchester Hospital will be discussing current treatments of shoulder, hip, and knee pain to provide you with some valuable information. Just some business to get started with the webinar. As time permits at the end, we will take questions and answers from some of your pre-submitted questions from registration. Please put any other questions that you might have that come up during the presentation in the chat function. If your question is not answered during the presentation, we will have a survey that comes up at the end and you can submit your question there. But you also can feel free to email sshapiro6@northwell.edu or call 914-362-6133. If at any time during the presentation you're interested in booking an appointment with the Orthopedic and Spine Institute, please feel free to private message us using the chat function, your name and contact information, and one of our providers will get back to you for assistance. You can also provide your contact information, like I mentioned, at the end in the survey that will automatically pop up when this webinar ends. Your contact information and name, of course, will be kept strictly confidential. If at any time you're interested in scheduling an appointment with the Orthopedics and Spine Institute, please call 914-362-6133. You can also always email Susan Shapiro at sshapiro6@northwell.edu. Okay, let's get started. Dr. Cabe, I'd first like to introduce you. Dr. Victor Cabe, welcome. Dr. Cabe holds Dr. Cabe holds several leadership roles at Northern Westchester Hospital: Chairman, Department of Surgical Services, Co-Chair, Department of Orthopedic Surgery, Co-Director of the Orthopedic and Spine Institute, and Director of Sports Medicine at the Orthopedics and Spine Institute. Dr. Cabe will go over a few different treatments for knee pain. So to start, Dr. Cabe, can you tell us what are the common causes and conditions that lead to knee pain?
So knee pain can be caused by a lot of different things. It can be caused by an overuse injury like tendinitis, but what we're going to talk about today and focus today is arthritic knee pain. And what arthritis is when the cushion between the bones is worn down and the bones start to rub on the bone. That causes friction, swelling, pain, and that's a leading cause of knee pain.
Okay. Will physical therapy help my arthritic knee? And what role does physical therapy, what does a course of physical therapy entail?
So one of the very first things we do when we see someone with an arthritic knee is we always try physical therapy, because physical therapy can loosen up a joint, it can strengthen the muscles around the joint, and even though the arthritis that you have is still there, oftentimes it can make it livable and more tolerable, and either delay or maybe negate the need for knee replacement or a joint replacement.
What are the benefits to cortisone injection, gel injections, or stem cell therapy for knee pain?
So a cortisone injection is kind of a quick fix. It's a medicine that's injected into the knee that actually works fairly well. It tends to get the swelling and the pain out of the knee within a few days. And for some people can last for months and months, and other people only last for a couple of weeks. So it's not a long-term solution to the problem, but oftentimes can kind of get you over the hump. Sometimes it's used in conjunction with therapy, meaning that the knee is really too painful to do therapy, so you can do a cortisone injection to get the inflammation down and then be able to do the therapy. The gel injection is a little bit more of a longer-term solution. It's actually a lubricant that's injected into the knee, and that actually provides a cushion or a lubrication to the knee joint, which tends to work for a lot longer of a period of time than the cortisone injection. And then when you talk about stem cells or PRP, those are what we call biologics. They're actually, think of them as a biologic solution to your pain. Theoretically, it's basically cells taken from your own body. If you take it from the blood, it's spun down into the platelets, which are the healing cells that can be injected into the knee, and that can alleviate the pain. There's a little controversy regarding them. Some people think they work really well. Other people think they don't work so well. So it's one of these 50-50 type of things right now.
And how do you know if you are a candidate or ready for joint replacement surgery?
So I tell my patients that they'll know, meaning that if you've done the physical therapy, you've tried anti-inflammatory medication, you've done the injections, you've modified your activities, and basically life is not fun anymore. You have difficulties, not running a mile or two, but really just getting around with your family and going on vacation and doing day-to-day activities. When the knee interferes with that, that's when most people say, hey, I'm ready for replacement.
Okay, thank you, Dr. Kabe. And now we welcome Dr. Evan Karras. Hi, Dr. Karras. Dr. Karras is the co-chair, Department of Orthopedic Surgery, co-director from the Orthopedic and Spine Institute. Dr. Karras will be speaking about total and reverse shoulder replacement, so moving joints now. Dr. Karras, can you tell us what are the common causes and conditions that cause shoulder pain?
Thanks, Amy. Sure. Very similar to what Dr. Kabe just described, there are two broad categories of conditions or problems, if you will. There are the traumatic problems, such as fractures or torn tendons or torn labrum in the shoulder. And then there are the degenerative problems, which are the arthritic problems. So within the arthritis category, you have the typical wear and tear arthritis, such as osteoarthritis. And then you have more genetic or hereditary types of arthritis, such as rheumatoid arthritis, which is an inflammatory type of an arthritis.
Okay. And what are the treatment options for shoulder pain?
So treatment options for shoulder pain depend on the cause of the pain, of course. So some of the acute traumatic injuries do benefit from surgery rather than conservative treatment. If you have an otherwise healthy, normal shoulder and you have an injury that results in an acute tear of a tendon, we like to restore that anatomy as soon as we can to get the shoulder functioning well. On the other hand, there are many conditions of the shoulder, such as arthritic conditions, as Dr. Kabe outlined, which are initially always treated conservatively, and many patients do very well with conservative treatment before eventually possibly needing surgical intervention.
Okay. How do I know if I would benefit from shoulder replacement, and what are my surgical options?
So great question. Again, the need, we always use the air quotes when someone asks us if they need shoulder surgery or a shoulder replacement or a knee replacement. The need is really based upon quality of life. So the shoulder sort of gets second billing to hips and knees because, the hips and the knees get you from point A to point B. But unless you have a good shoulder, once you're at point B, you can't really do much. So our shoulders help us interact with our environment, which is very important for our quality of life. So when you lose your quality of life because either you can't do your activities of daily living, very common in shoulders, you can't brush your hair or brush your teeth. You can't participate in sports or exercise that you love to do, which is very important for our well-being and our quality of life. And sometimes it gets so bad you can't sleep at night. And like Dr. Kabe said, patients tell us when they're really suffering and when they really need surgery. And then when surgery is needed, there are different types of surgeries that we can talk about.
Okay. And to illustrate your point, I'm going to show some videos, right, Dr. Karras?
Yeah, so I just wanted to show the audience, just to give you a basic concept. Before you start, let me just explain,
Sure,
this is
of course.
Just to give the audience a basic idea of what is a shoulder replacement. Again, most of you probably know lots of people who've had hip replacements and knee replacements, but you may not have known anybody who has a shoulder replacement, much less common. So what we're basically doing is with any joint replacement, we're trying to recreate the anatomy as close as we can to the way it was before the arthritis set in. So in order to do that, we're removing the ball. So you can see in this picture right here, before you start the video, that ball is not smooth, it's rough. That's kind of a cartoonish representation of arthritis, if you will. And so that ball is of no use anymore. And so we remove the articular surface, the part of the bone that has the cartilage on it. We have special instruments now that allow us to reproduce the anatomy, and we remove the ball. So you can go ahead and show this. The old days, we used to have to use stems that go down the bone. Much more modern prostheses just involve a little plate that we put on top of the resected surface. And that's a titanium plate. And it gets screwed in with a titanium screw, which initially is very, very strong. And then your bone will actually grow into that cage screw. And then we put that metal ball on top that you saw, which actually recreates or replaces the cartilage of the shoulder. On the other side, we don't have a video of it, but there's basically a polyethylene, which is what people call the plastic part of the joint replacement that resurfaces the socket. So this is a procedure that works great for people who have a normal rotator cuff mechanism and have arthritis. And that is the surgery for that subset of patients. But there are also patients who don't have an intact rotator cuff mechanism. And in the past, many patients have been told there's nothing we can do for you. You just basically have to suffer and live with your arthritic shoulder, because the results of shoulder replacements that were done in those patients with no rotator cuff tendons were miserable. Well, with the advent and the development of the reverse shoulder replacement, it has really been a game changer. And when we say reverse shoulder, let's show that second video.
Yep. Basically,
we're reversing the ball in the socket. So here you can see, again, now we've put the socket where the ball was on the other replacement, and we've put the ball where the socket is. And if you stop the video right there, basically you see what this does. It creates basically a force couple, which allows your muscles to elevate your arm. If you don't have an intact rotator cuff, it's very difficult for you to lift your arms up and interact with your environment in space. So this prosthesis substitutes for the ability to lift the arm up and hold your arm up in space. And it's great for pain relief and improves function significantly in patients who in the past have been told there's really no other option for them.
That's amazing. It's amazing. That's how the technology has advanced. So what is the recovery like, and what activities can one do after shoulder replacement?
Sure. So these days with modern anesthesia techniques, the recovery is really not nearly as painful as it used to be. The anesthesiologist usually inserts an interscalene block, which is a nerve block using an ultrasound machine to numb the arm up. So the first 24 hours are relatively pain-free. In the surgery, we also inject a long-acting numbing medicine that allows for an easier recovery. Many patients have surgery out on an outpatient basis now for shoulder replacements. It's very common. Most of my patients go home the same day of the surgery, or at most one night in the hospital. The recovery, the first 6 weeks is the hard part because we're protecting a tendon that we have to repair at the time of the surgery. So the arm is in an arm sling for 6 weeks, but it's removed several times a day to perform exercises. We usually start physical therapy within a few days of the surgery to help with early range of motion. And then we progress to strengthening after 6 weeks once the prosthesis has healed in and the soft tissues have healed. And most of my patients are driving within 4 to 6 weeks. And a full recovery is anywhere from 3 to 6 months, depending upon the patient and the degree of arthritis preoperatively. Activity-wise, you can be very active after a shoulder replacement. You know, you can certainly participate in weightlifting exercises in the gym. Activities of daily living are much easier after your shoulder replacement than they were before. You can engage in sports activities after shoulder replacement. Now, you have to understand the expectations are not that you're going to be made, 21 years old again and be throwing line drives from center field to the catcher, but easily participate in recreational activities and sports and The results of shoulder replacement, again, it's not as common as the hip and the knee, but with our new methods of implantation, our new technology of the bone sparing prostheses that we use, with the help of the anesthesiologist to allow for an easy recovery after the surgery, the results are great, approaching, 95 to 97% good to excellent results in our long-term literature, which is basically equal to the hip and knee literature now with our current techniques. So it's a great answer for people who failed conservative measures. Their arthritis is severe. They have a loss of quality of life. And now even more patients can benefit with the advent of the reverse shoulder replacement.
Thank you, Dr. Karras. And now we have Dr. Joel Buckholzer. Welcome. Dr. Buckholzer is the Director of Joint Replacement Surgery at Northern Westchester Hospital and the Orthopedic Spine Institute. Dr. Buckholzer will talk about knee replacement surgical options. So moving up right along the body parts. Dr. Buckholzer, what are different surgical options for knee replacement surgery?
Well, thank you. Thank you very much for having me, Amy. It's a great webinar so far. Love hearing Evan's talk on the shoulders, as it's very exciting what we can do in the shoulders. So equally exciting is what we can do in the knee now. We can do complete knee replacements, which we've traditionally done over the last 4 or 5 decades, or we can do partial knee replacements. So for example, we can break the knee up into 3 different compartments. One's behind your kneecap, and if that compartment has severe arthritis, we can replace just that compartment of the knee. If the arthritis is on the inner part of your knee joint, we call that the medial compartment. You can replace just the medial compartment of the knee. And similarly, if the arthritis is on the outer part of your knee joint, you can just replace that part of the knee. And in doing so, you can end up with a more natural feeling knee replacement because you don't really affect the ligaments that hold the bones together. But more commonly, what we do is a complete knee replacement, because most of the time that people come to knee replacement surgery, they've worn through most, if not all, of their knee. And in that situation, we replace all 3 parts or all 3 components of the knee.
So what is the Mako robotic assisted surgery for partial and total knee? And what are the advantages to robotic surgery?
So with the advent of robotics in orthopedics, which has been around for a good 15 years or so, but has gradually evolved to the point where it's now become a common procedure, we can increase the accuracy and the precision of the surgery. We can make an operation where it was the same for everybody into a very personalized procedure for each patient's individual anatomy. And in order to do that, we use a special robot that allows us to be have more precision surgery. We do this based on some of the stuff we do prior to the operation, where we can do an image of the knee and use that image of the knee to do the surgery in virtual reality. And I think I have a video that shows the kind of the concept of this operation. So on this video, what we're looking at to start is the robot itself. And this robot is wheeled into the room. It's robotically assisted. And what it allows us to do, it allows us to do the operation personalized to every single patient. The surgery itself will protect the ligaments and the tendons around the knee so that you don't do any damage to them. And it does so by creating a 3-dimensional virtual anatomy model of the knee joint. So the soft tissues and the ligaments are protected during the surgery. Initially, what we do is we do a CAT scan of the knee. A CAT scan is a 3-dimensional picture of the knee joint that's loaded into specialized software, and then it creates this 3-dimensional model of the knee joint. 3-dimensional model is given to the engineers, and then the engineers actually put the knee replacement on that model. Then we get the software, and I can adjust the software with the knee replacement to position the knee replacement exactly as it should be in the patient. And then once that preoperative plan is created and we have the actual knee replacement implanted, we go to the operating room. And in the operating room, we register the patient's anatomy and basically match that to the CAT scan and the 3-dimensional model. And once the patient's model and the real model match one another, we can do the operation in virtual reality and adjust the knee replacement in the patient while we're moving the patient's leg, and see what happens as we move the leg. We can adjust the ligaments so that the tension of the ligaments are correct, We can assess the range of motion of the knee, and we can assess how loose or tight the knee is. Then the next step is we bring in the robotic arm, and then the robotic arm allows me to cut the bone exactly as I had designed the knee replacement. And it's virtually like playing a video game. We remove the green stuff that you see with the saw while we're watching TV virtually, and it happens in the patient's knee as we do it. The robotic arm doesn't do the surgery, we do the surgery, but it directs us so that we can't cut the bone in the wrong place. Then the next step is we put the components of the knee replacement, much like the shoulder replacement, in place. And then we hit the recovery room and we get the patient up out of bed and we begin the rehabilitation process. The operative procedure itself allows us to do the surgery quicker and more accurate than that of a traditional knee replacement. Studies have shown that patients have less soft tissue damage when you do the knee replacement this way and can actually have a quicker and less painful recovery.
It's amazing. So the question is, does the robot actually do the surgery? And is the robot safer than the traditional surgical methods?
Yeah, so I think like anything else in medicine, everybody argues every different direction, and you can find people to argue one way or the other. But having been, an orthopedic surgeon for over 30 years and having done about 6,000 or 7,000 knee replacements during that period of time, I can tell you that this operative procedure in my hands definitely advances my skills as an orthopedic surgeon to do a more precise knee replacement, to line the components up appropriately, to tension the ligaments appropriately, so that when you're done with the operation, every knee replacement I do is I consider perfect, that I've walked out of the operating room and have done the best service that I can do for the patient. The robotic arm does not do the operation. We guide the robotic arm, but it has something called haptics, which protects the soft tissues because it only allows you to cut the bone in the plane that you have decided to cut the bone. It doesn't allow you to escape boundaries that you've created for cutting the bone. So it's a very safe procedure. I've been doing the complete knee replacement with the robot for about 3 years and have done the partial replacement with the robot for about 6 years. So I have quite a bit of experience with it. And a lot of the members of my group I've trained to do the robotic surgery, Dr. Kabi being one of them. And, he can speak to the precision of the operation and how it really, changes our ability to do a better knee replacement.
Thank you very much, Dr. Buchholzer. And now we have Dr. Evan Hawkins. Welcome. Dr. Evan Hawkins is orthopedic surgeon at Caremount Medical. Thank you for being here.
Thanks for having me.
Moving on to the hip. What are the common causes and conditions that cause hip pain?
Sure. So much like some of our other panelists have said, it really kind of depends on what exactly how you're defining hip pain. So one of the more common things we see that I see in regards to hip pain is pain over the outside of the hip. That should be distinguished from, typical pain from arthritis. Pain over the outside of the hip is often related to a condition called bursitis, sometimes tendinitis. Essentially, what bursitis is a focal inflammation in a space, usually between a bone and a ligament or a bone and a tendon. In this case, it's between the IT band, which you've probably heard of, which is a long strip of tissue on the outside of the hip, and the bone of the trochanter, which is the side of your hip. It's basically what that can do is tightness in that structure can cause a friction in that area and cause inflammation to develop. People often complain of pain on the side of their hip when they're sleeping, sometimes pain getting up from a chair, especially when you've been sitting for a long period of time, getting in and out of a car, things like that involve lateral motion of the hip. Tendinitis is another form of lateral hip pain. Again, most of these conditions can be treated with physical therapy. Sometimes cortisone injections can help a great deal, anti-inflammatories, changing the way you interact with the world by changing exercise patterns, stretching more regularly. These kinds of things can help with that sort of pain. Groin pain is an entirely different animal. So groin pain often indicates a problem with the hip joint itself. In older individuals, this is often arthritis. There's two kind of flavors of arthritis. There's the sort of degenerative or osteoarthritis, and then there's the inflammatory group of arthritis, of which rheumatoid arthritis is probably the most common. In the end, it leads to the same type of problems we've seen in the other joints, which is the progressive loss of cartilage. And when you lose cartilage, basically your bone no longer has protection against the forces that your body is withstanding from walking and activity. So it causes pain because the bone is no longer able to protect itself.
Thank you. And what are the treatment options for hip pain?
Treatment options, of course, depend upon the cause of the pain. In the case of arthritis of the hip, one thing we have found is that therapy, while is always important to maintain flexibility and strength, is not quite as effective as a non-operative treatment as it is in other conditions like knee arthritis. With regards to surgical treatment options for hip arthritis, there's really, once it gets to a point, there's really two options. And one is what's called a hip replacement, which is far more common. And the other one's called a hip resurfacing, which is a different kind of replacement that is not done in a widespread manner. It's kind of a place, more of a specialty operation. You have to go certain places for. I'd say the mainstay of treatment for arthritis at the end of the road is a hip replacement. Cortisone injections can be considered. I don't generally recommend them to patients with severe arthritis because I find the results to be really short-lived. Most patients have about 2 weeks of relief, and it can be useful when you're not quite sure where the hip pain is coming from. It can be a very good diagnostic tool. Currently, the FDA doesn't really approve gel injections for the hip, so we don't have that option available. It's an off-label use right now. But those are kind of the mainstays of treatment, either injections or surgery.
So now to learn a little bit more about hip replacement, we're going to play a game. So you will see questions pop up on your screen using the Zoom poll function of Zoom. And you can take a guess and play along with us. Or if you're watching us on Facebook, I will repeat the questions so you can take your best guess. And Dr. Hawkins will explain the answers as we go. Are you ready, Dr. Hawkins?
I'm ready.
Okay, let's launch the first question. Oh. Let's try that again. Technical glitch. Let me try this again. Sorry, everybody. Okay. Can you see that box? It's not popping up on the screen yet, everyone. No? Okay.
I don't see it yet.
All right. I'm going to read the questions because I don't want this to prolong our learning. Okay. So true or false? Anterior approach to total hip replacement is a brand new procedure, completely different from traditional approaches. Dr. Hawkins, is that true or false?
I would say that's false. So the surgery, the anterior hip replacement surgery, has become a lot more popular in the last decade, 2 decades or so. I think a lot of the reason for this is because we have gained more understanding about the anatomy in the front part of the hip. We've developed instruments that allow us to do the surgery with much more efficiency. We started, pioneering surgeons started treating arthritis through this approach probably before the posterior or typical traditional approach to the hip was ever created or discovered. So people started using the anterior approach actually to implant what's called sort of a resurfacing. Basically, they were putting these glass cups inside the hip joint. This was back in the early 20th century, but they were using that anterior approach, very similar to the one we use today, safely. Unfortunately, the implants they had being made out of glass weren't exactly appropriate for weight transfer, so some of them would break, and that would obviously cause a somewhat unhappy situation. Thankfully, things have gotten a little bit better with regards to anterior hip replacement nowadays. So I think our box actually just came up.
Yeah, let's try that again. This is our Zoom poll too. We're having a little tech glitch, but that's okay. Let's try again. There we go. This is now the second question just popped up. I just want to make sure you finished your first question.
Yep.
Okay, so true or false for question number 2, anyone with hip arthritis is a candidate for the anterior approach. So let's give everyone a chance to answer. Is that true or false? Got a lot of varied answers here. All right, And let's see what everybody says. The majority of people say false. Dr. Hawkins, what's the answer?
Well, the majority of people are right. I think that I'd like to think that everyone's a candidate. I certainly believe it's a great operation. I tend to prefer it as an approach compared to the posterior approach. I do both. I think that it's all kind of a question of how comfortable the surgeon is. For me, the anterior approach is how I am most comfortable with the hip, but there are certain patients that can have a little bit of an issue. The one thing with the anterior approach has shown is there can be a slight tendency for wound healing problems. So problems with the incision healing after surgery in patients that are very heavy, have a lot of excess skin or fat tissue over the front of the hip, that can be a bit of a concern. May not be true for every surgeon, but for me, I tend to suggest another option for those patients. The other, absolute contraindication sometimes is patients with a certain amount of hardware in the hip can be a little tricky. Revision surgeries can be a little trickier through the front, but I think as we learn more and more techniques, as we are expanding on the use of technology like robotics, as Joel spoke on, I think we're getting better at handling even some of those more difficult patients.
Okay, question number 3. True or false? I will have fewer postoperative restrictions after having anterior total hip replacement compared to more traditional approaches. Let's see what the audience says. True or false? Give them a minute to respond. I think this audience was paying attention. All right, the majority say true. What's the answer?
Well, that is true. So I think that's one of the big advantages of this approach is because we're not going through the back of the hip and we're not cutting muscles, we're not removing those stabilizing forces from the back of the hip. That kind of reduces the risk a patient's going to have with a dislocation, which is when the prosthetic ball that we're putting in actually pops out of the socket. So because we're not going through those muscles, we don't have to worry quite as much about, taking care of positioning of the leg after surgery. So one of the questions I get a lot is, can I sleep on my side? Can I sit in a low chair? Am I allowed to cross my leg? And I generally don't have any problem with that after an anterior approach. There's one thing I suggest patients avoid initially for the first 6 weeks, and that's what's called a straight leg raise. This is just a personal opinion I have, but I think it puts a little too much stress on the quad muscle in the front of your hip, which is still healing after surgery. It's not that you can't do it or you're in danger of popping your hip out doing it. It's more that it's going to cause a little extra pain. So patients just generally don't want to in the first 6 weeks. But other than that, you're more or less free to move around as you did before surgery.
Okay, a couple more questions in our game. True or false? After your hip replacement, you will need to spend a night in the hospital. This is an interesting one. True or false? All right. Giving another second for the audience to answer. And the majority say false. What's the answer?
I agree. I agree with the majority here. So I think this is something that's changed, and a lot of people are still a little bit cautious to do, but I think we have started to move away from, obligatory admission to the hospital after hip or knee or shoulder surgery. I think some of the newer techniques we're using, such as, approach and smaller and muscle sparing approaches, but even more than that, we're dealing with pain medications afterwards. We're trying to use fewer narcotics. We're using spinal anesthesia. We're using local medications at the joint that really help control the pain and make people move quicker. And therefore, they're getting up faster. We're getting moving quicker. So we really are trying to send patients home. And I think a good percentage of patients, healthy, younger patients especially, are very good candidates to go home after joint replacement surgery. That's something ultimately that you should have a conversation with your doctor about. And, there are things you can do to prepare for that possibility, such as getting your house in order, making sure that you've got, the appropriate services set up afterwards, physical therapy, and all the medications sent to your house. And that's something the hospital is really good at getting in place so that you can have a quick recovery at home.
That's great. Yeah, so Northern Westchester really provides a holistic approach to discharge planning.
Yep.
Okay, 2 more questions. Number 5, true or false? After your hip replacement, you will not be able to care for yourself, climb the stairs, or get out of bed, and you will need round-the-clock assistance. Audience, true or false? I think we have a very smart audience that was listening to words that you were saying. The
Or
majority.
My questions were too easy.
No, I think it's good. All right. And the majority say false. What's the answer?
I agree. That's correct. So, it's kind of an extension of the last question, but you really are going to be expected after an anterior or a posterior approach, you're going to be expected to be able to do these things, and that's what physical therapy is really crucial for in the initial stages. Before you even have dinner on the day of surgery, you're going to have climbed some stairs, you're going to walk with physical therapy, and you're going to need to get out of bed on your own. We're rarely using Foley catheters, so you're going to have to get up and use the bathroom on your own. And that's part of the whole goal of early mobilization after surgery. So that's what makes it safe for you to go home. It's obviously dependent completely upon your preoperative function. Patients that were walking with a walker or a cane are still going to likely be doing so after surgery for a little bit. But in general, that is our goal, is to make patients able to care for themselves.
Okay, and our last game question here. True or false, recovery from anterior hip replacement is shorter than more traditional approaches? True or false? I like how our questions went on. We had more and more people participating in our game. Means we're doing something right here. Okay, and the answer is that most people said true.
And I generally agree with that. I think I think that's studies. There have been studies that have shown that the recovery, especially in the first 6 weeks, is accelerated in anterior approach. And that really refers to the amount of pain patients are in and certain measures we use to evaluate a patient's function. I think if you look down the road 6 months to a year later, the recovery is probably similar. But the first 6 weeks, I think, to me, are very important because, I think that's where patients develop confidence in the operation. They develop confidence in their own ability. And it's just, I think, getting a very quick start to recovery is really beneficial to the whole process of recovery as a whole.
Thank you, Dr. Hawkins. Thanks for having some fun with us, too.
Pleasure.
All right, now we'll take it back to Dr. Kabe. Northern Westchester Hospital takes every precaution regarding COVID-19 and surgery. Dr. Kabe, is it safe to come to Northern Westchester Hospital for my surgery? And can you explain the COVID safety protocols we have in place? And I will share your slide as well.
So, Amy, during this pandemic, obviously, it's been a tough situation for all of us. And I think during the first wave, we basically shut down the operating room in March, April, May, June. We started opening back up again. And we were shut down. Obviously, we would do emergency surgeries, but we were not doing semi-elective surgeries at all. We've learned a lot about COVID since the first wave. And fortunately, knock on wood, we've been able to run a full surgical schedule at Northern Westchester Hospital throughout the second wave. And we've done so because we've implemented very strict safety guidelines that both protect the patients, protect the nurses, the doctors, the techs, everybody. And so to highlight some of the precautions, this is what we do. Every single patient has a COVID test 3 days prior to the surgery. If the test is positive, obviously they can't come to the hospital, can't have the surgery. if there's a COVID positive patient that requires an emergency operation, they will be done at the end of the day in an isolated room and isolated from all the other patients. So we're not doing a lot of COVID positive patients. There are people who are critically ill and do need procedures, but we have a way of isolating those patients from the rest of the population in the hospital. All the staff and patients have their temperatures taken as they enter the door of the hospital, and they're all screened for symptoms coming to work and entering the building. Everyone in the hospital obviously wears masks, patients and staff. Staff wears PPE, face masks, goggles, gowns, N95 as needed. We use ultraviolet light in the operating rooms. There's something called purple sun, which is basically an ultraviolet light that terminally cleans the operating rooms. And we don't allow visitors in the ambulatory care center, post-anesthesia unit, unless it's a pediatric patient. So bottom line is, with these protocols in place, we've been able to pretty much maintain a normal surgical schedule. Some patients get canceled because they're COVID positive and they have to reschedule when they're negative. There are emergency surgeries where people do need to have surgery if they're COVID positive, but those are handled in a very segregated way so as to not cross-contaminate anybody else in the hospital. And with these protocols in place, we've been able to very successfully continue offering the very best of care to our community throughout the pandemic. And early on, patients were a little scared, which I understand, but I think as word has gotten out and as we've done more and more patients in the hospital, we're really back up to a normal schedule. And if you're suffering and you need surgery, there's no reason you can't have surgery done at Northern Westchester Hospital. I think we've taken a lead on this in the community. Northwell, in general, has taken a lead, I think, in COVID for the entire New York metro area. And Northern Westchester Hospital is a Northwell hospital, and we've been very, very fortunate to have leadership at the hospital that's been able to work with us, with infectious disease people, to formulate these plans and these protocols to protect everyone, but to allow us to continue providing the state-of-the-art care to our community. One more thing I just want to touch upon before we get to the, Amy, if you allow me, I'm going to kind of go off this a little bit, just because this webinar has been so amazing and I've been hearing such great talks. It reminds me how great of a place Northern Westchester Hospital is. I've been at the hospital for over 20 years, close to 25 years. And as technology has gotten better, we at Northern Westchester Hospital have always been a leader at that next step. We've been one of the first to do robotic surgery. As Dr. Buchalter mentioned, we were doing partial knee replacements 6 years ago, and more recently of doing full knee replacements utilizing robotic technology. We use some implants with CT scans that can make 3D models of your knee and pre-plan the surgery that way. We have advanced instrumentation, as Dr. Karras has mentioned, doing shoulder replacements in a minimally invasive way that's much easier and faster to recover from than other methods. Dr. Hawkins has talked about the anterior knee replacement, and that's been something that we've been a forefront of in terms of doing at Northern Westchester Hospital as well. And so these are things that oftentimes are really not available even in some of the big city hospitals in terms of the access that we have. For instance, we have two different robotic systems. We have a Navio and we have a Mako. Both have pluses and minuses. Both can be used in different ways. But the fact that we have both robot systems, where I don't think any other hospital in the region has both technologies, and that's something that our surgeons could use and do use, and can bring the very best of care to the community. So we also have a very robust same-day surgery program with an excellent anesthesia group that's able to do what's called nerve blocks to kind of deaden the pain, but not deaden it to the fact that the leg can't work. They can deaden the pain without deadening the muscles. So you can still get out of bed and walk around and be able to go home the same day. And that's been a huge breakthrough. And again, we've been a leader at that at the hospital as well. So if anyone's even thinking of having a joint replaced, I think especially in today's times of pandemic and COVID. I know there's always sort of this rush to say I have to go to the city to have the surgery done. I think we do it better than the city. I think we do it safer than the city. And I think our technology rivals that of the city. I think we have the very best, the newest. And I think our surgeons, we've all trained in big city hospitals and can bring that to our community. So I know I kind of went off script a little bit, but I was just kind of motivated by hearing our speakers. And, you know, I live in this world with these doctors all the time, but sitting back and hearing them talk about it, it just brings to mind of how special a place that we have here. And I'm fortunate for our community that we're here, and amazing doctors and staff and administration. So yes, I started by talking about the safety protocols. It's very safe, but I think there's a lot more that we have to offer as well. So thank you.
No, that was a good tangent. That was excellent. It wasn't even a tangent, because it's true that Northern Westchester really provides the community with safe care that's close to home, and the community approach that we all need right now, with the latest technology and the expertise from all of you. So thank you for saying what you said. I agree. So to schedule your appointment with the Orthopedic and Spine Institute, you can call 914-362-6133, or you can email sshapiro6@northwell.edu. Like I mentioned at the end of this call, there will also be a survey that pops up, and you can put your name and contact information, completely confidential, to either ask a question or for us to call you to schedule your appointment. We will certainly provide you with that service. So now, thank you everyone, to transition into questions from our registration. There were a lot of questions at registration. And again, if for any reason we don't get to your question, because we've had a lot of questions coming through the chat here, please feel free to repeat your question at the survey, and we will get back to you with an answer at the end. Okay, so the first question is for Dr. Buckhalter. Dr. Buckhalter, if you need both a hip and knee on the same leg replacement, which do you do first? And have you ever done both at the same time?
So I think traditionally, there was a point where we were doing double joint replacements, like double knee replacements, double hip replacements on patients. But nobody really ever did a hip and a knee at the same time on someone, because the recovery in the past was very different for a hip replacement than it was a knee. There was the fact of being very cautious with the hip replacement, avoiding certain positions and not overdoing it with the hip replacement, which is also true about the anterior hip replacement now. Whereas the knee replacement was always about hit the therapy, get the knee moving, no pain, no gain, the whole kind of gestalt being very different recoveries. So really nobody really does hip and knee replacements together. And a lot of people have abandoned double knee replacements because most of the studies show a higher complication rate, even more recently in some articles, even on the younger patients. So we're really more likely to do a single replacement. And with the single replacement, you know, the advantage nowadays is with the blocks that Dr. Kabe was talking about, is that we can get the patient up that day, 2 hours after surgery, walking on their knee or their hip, and actually get them home more than half the time to do their rehabilitation at home. So the recoveries when you do a double would not be like that. You'd end up going to a rehab hospital and maybe being in bed for 3 days before you got out of bed. So right now it's kind of a single replacement, get back on your feet very quickly, and we can get you out the door very quickly. Then as far as the staging of whether you do a hip first or a knee first, there's a lot of controversy. You know, if you have a lot of deformity in your knee, you're very bow-legged or knock-kneed, it may be smart to correct that deformity first before you do the hip. However, if the patient is incapacitated with hip pain, then sometimes you would do the hip before the knee. So there's a little bit of latitude that we use to make that decision. So there's no, you do it this way versus you do it that way in the hip and the knee world. There is, however, a group of patients that come in with knee pain, and the knee pain is actually referred from the hip. There are occasionally patients that come in with knee pain and they have a normal knee and the pain is purely from the hip joint. So you have to rely on your surgeon to evaluate you and discuss that with you, because we have done surgery on people who have knee pain and have done a hip replacement and got rid of their knee pain. Vice versa, sometimes the patient will come in with an unhappy knee replacement, from another doctor, and I'll see them and examine them and say, your knee replacement's done perfectly. You have a bad hip. And the pain is actually coming from their hip, and they're unhappy with their knee replacement. And that's happened many, many times. So there is a very strong relationship between the hip and the knee, and believe it or not, also the spine. So those are the three areas that we as orthopedic surgeons have to look at when we evaluate a patient with hip and knee pain. So I'm sorry to ramble, but that's kind of the long answer for the short question.
No, it's good. It's very interesting. Very, very interesting. Dr. Hawkins, is there a way to know what intermittent localized hip pain signifies?
Sure. I think a lot of the pain we deal with is intermittent, especially in the early, stages of arthritis. I think it all depends on where the pain is. As I was talking about earlier, pain in the groin that's intermittent without any history of trauma is could be one of two things, arthritis being one of them. Tendinitis of one of the muscles in the front can certainly do that. Arthritis pain tends to be kind of deeper, achier, like a toothache, worse with activity, associated with stiffness and loss of motion, achiness in the morning, things like that. Pain on the side of the hip, intermittent pain on the side of the hip could be a tendinitis or a bursitis problem, could be a tear in the tendon, certainly if it's, gone on long enough. That's sort of the end of the road. But you need an evaluation, obviously, first, because like Dr. Buchalter is saying, there's a relationship between the back, the knee, and the hip that you need a specialist to kind of get x-rays and determine exactly where that pain is coming from.
Thank you. Dr. Buchalter, another question for you. What is the role of scar tissue from earlier knee injuries as we age?
Scar tissue is a big issue because, if you look at knee replacement, the results after a knee replacement, as far as the range of motion of the knee, how much mobility you get back after a replacement, the only factor that determines the motion after the knee replacement is the range of motion before the knee replacement. So if someone has, scar tissue from a prior injury or limited mobility of their knee, just from the progression of arthritis, it can make the return of the range of motion more difficult for that patient. So we identify those patients ahead of time, we counsel them, and we kind of follow them much closer in the postoperative course to make sure that they're regaining their mobility as they should. So you probably will see those patients every 2 or 3 weeks versus every 6 weeks or so. But it definitely has a role, and it's something that does determine the ultimate outcome of the replacement.
Thank you. Dr. Karras, how long can I take pain medication or anti-inflammatories without causing serious side effects?
That's a very good question. There are patients, unfortunately, who have either chronic pain syndromes or have conditions. Maybe they're not good surgical candidates for one reason or another. And there are people who need to take these medications for a long-term basis, on a long-term basis. And as long as, if you're going to do that, you're monitored by your internist. These medications can affect the liver and the kidney function. So that is one of the big concerns about these medications. So if you're going to be doing that, by all means, you need to be closely followed by your internist to make sure you're not harming those organs. Also, about a week to 10 days before any type of orthopedic surgery, we like to have patients off of all the anti-inflammatory medications so we don't increase the risk of bleeding and hematomas postoperatively.
Thank you, Dr. Karras. Dr. Kabe, this is a specific example. For, say, an 85-year-old individual with underlying conditions such as congestive heart failure or AFib, would surgery even be allowed?
So that's a very good question. It comes up a lot. Oftentimes, people can have illnesses that are well controlled. I mean, AFib is AFib, and it can be well controlled. Congestive heart failure can be controlled. Multiple medical problems can be controlled. So that's something that needs to be assessed oftentimes by the cardiologist, the primary care physician. Age in itself is really not factor. I mean, some people who are 85 are very active and very healthy and look like they're 70. Other people who are 70, look like they're 85 or 90. I mean, it's all over the place based on health and genetics and things like that. So I don't really look at the chronological age. I kind of look at their age in terms of how functional people are and how strong they seem to be. And in consultation with their primary care physicians, trying to figure out what the best thing is. I've told the story many times of a 90-year-old lady who came to me wanting a knee replacement. And I said to her, yeah, you're a little old, maybe we shouldn't. But if your doctors clear you for surgery, I'll do your surgery. And then she went and got her doctors, and she came back with the letters, and her doctors cleared her for surgery. I did her surgery. She did great. A couple years later, her other knee started bothering her. She's now 92, 93. I said, listen, we're pushing it. But if your doctors clear you, I'll do the surgery. At this point, the doctors figured at 93, they're not going to clear. So she came back very disappointed and not being able to have her surgery. So for years, I treated her with cortisone injections and gel injections and things like that, which helped to some degree, but really never made her other knee as good as the knee that had the knee replacement. I remember when she came to me at 98, she said to me, she says, you should have did my other knee when I was younger. Now I agree, I'm too old. So my point being is that, you can't take someone's chronological age. You got to take their overall fitness. And in retrospect, if I would have done her knee at, 93, she would have had 5 years. I mean, seeing how strong and vibrant she was for 8 more years afterwards, she would have done well, but who would know? So the bottom line is it's not your age, it's your activity level, it's some other medical things. And nobody's really ruled out unless you obviously have significant comorbidities. And that's something that your primary care doctor's cardiologist would let us know.
Great, thank you. That's a great story. And to piggyback on that, we had a great comment in the chat come through that someone said that their 80-year-old mother recently had 2 reverse shoulder replacements and it was the best decision she made. So I think your comment about chronological age is very worthwhile. All right, Dr. Kabe, another question for you coming through the chat. Is there an alternative to surgery if I have advanced arthritis with bone on bone and the shots didn't work?
So listen, it depends on how much you're suffering. So if you've had shots, you've had physical therapy, you've tried some braces, you've tried medication, and your quality of life is such that life is just not fun, that your daily activities cause pain. You have difficulty sleeping at night, difficulty enjoying your family, difficulty going on vacation and just walking around. I don't know of anything else that will help. I mean, people talk about these stem cells and things like that, but when you have bone on bone, I've not seen that really work to any long period of time. So I think if you've tried everything else, you have bone on bone, and otherwise are in good health and have significant interference with daily activities, I think a replacement is probably the best option.
The next question is for both Dr. Kabe and Dr. Buckhalter. What are the latest developments on repairing a torn meniscus? Can we do that at Northern Westchester Hospital?
I'll defer to Dr. Kabe because he does all the meniscal repairs.
So yes, so first of all, we do meniscal repairs at Northern Westchester Hospital. There are what's called, we've advanced them to the point now where we do what's called an all-inside technique, meaning there's no incisions. It's done arthroscopically through 2 little micro incisions. It's fairly straightforward. Again, we have the latest and greatest technology at Northern Westchester Hospital, so we have the instrumentation to do this. The issue with repairing a meniscus is a meniscus doesn't have great blood supply. So after it's repaired, you can't get on it right away, start running around and doing immediate therapy like you would if you had the meniscus removed or part of the meniscus removed. You need to be on crutches for several weeks and probably take you out of sports for about 6 months or so. The downside of removing a meniscus or part of a meniscus is 20 years down the road, you develop some arthritis. So when you have very young people, we go to great efforts to try to preserve the meniscus and repair them. Once you get a little older, the blood supply is even less, meaning that there's less healing potential. And so sometimes in those situations, you're really better off just kind of cleaning up the meniscus and just saving whatever is torn and healthy and just cleaning up removing whatever's torn and leaving in place whatever is healthy. And then that way you can start therapy right away and get on with your life much sooner. So I guess that's, again, a long answer to a short question.
No, it's good. Thank you, Dr. Kabe. We have time for one more question, and it will be for Dr. Hawkins. Again, if you didn't have your question answered, please put them in the chat, the survey. It will pop up at the end of your screen and we will answer them. Dr. Hawkins, how long does a hip replacement last? And is there anything you can do if age or medical conditions prevent you from having hip surgery? Oh, you're muted, Dr. Hawkins.
Sorry about that. So I think I generally tell patients, about 15 to 20 years. Obviously, my goal is to never operate on someone again, to fix them and have it last forever. Unfortunately, these are mechanical parts, and we want our patients to be active. And so the more active you are, the younger you are that you have the surgery, probably the shorter, the interval will be. And so if you're 40 years old, you can pretty much guarantee, if you live a relatively normal lifespan, that you're going to probably need another surgery. So the second part of the question, I think, was, how can you avoid that second surgery if you do get older? Well, it kind of depends on the problem. I think as we get older, our activity level diminishes. So I think your tolerance for small problems with the joint replacement may be such that you can live with it, and medication and activity modification can work very well. And I think I see a lot of older people that in a younger person, I might indicate to revise the hip or the knee, but there's just not really, the risk benefit analysis doesn't favor that. The patients are living a reasonably normal life. So, unless the hip replacement or knee replacement really fails, what we say, catastrophic failure, and really is a serious problem that we need to address, surgery can be avoided. So I think it's never a reasonable thing to say, I'm not going to go through a joint replacement for fear of having to do it again. You have the surgery when it starts to negatively impact your life, no matter what age you're at. That's my opinion.
Well, great. Thank you, everyone. That was all the time we have for. I think this was a really dynamic discussion. Definitely gave everyone a lot to think about. So Dr. Kabe, Dr. Buckhalter, Dr. Karras, and Dr. Hawkins, thank you for your time and expertise tonight. And everyone who joined us, thank you so much for joining. Please take the time to complete the very, very brief survey that will pop up on your screen immediately after this webinar. Your feedback is so important to us about how you felt about the webinar and to see future programs. And again, if you would like to be contacted to schedule an appointment or to answer your question, please put that information in the survey as well. Thank you, everybody, and have a wonderful evening.
Thank you.
Take care.
Everybody. Thank you, Amy.
Bye. Thanks, everyone.
Thank you. Take care.